Here's our roadmap. We're covering 5 core domains today: medical errors, detecting and reporting, communication, quality improvement frameworks, and specific UI tools. Starting with Section 1, we're diving straight into the taxonomy of medical errors and accident causation. So the Institute of Medicine estimates up to 98,000 hospital deaths happen every single year just from preventable medical errors. For your exams, you need to lock in this exact definition. A medical error is the failure of a planned action to be completed as intended or using the wrong plan entirely to achieve a goal. Bottom line, it's a breakdown in either your plan or your execution. To visualize how these breakdowns actually reach the patient, think about James Reason's Swiss cheese model. The crucial distinction to make here is between latent errors, which are underlying organizational defects like poor safety training, and active errors, which are the unsafe acts happening right at the point of care. Serious harm goes down when the holes in the cheese align. Basically, the system's defensive layers fail to stop the hazard from slipping through. Now, when evaluating these errors, you've got to know the difference between errors of commission and omission. Commission means you proactively did the wrong thing. Omission, though, is failing to do the right thing. Think forgetting to prescribe DVT prophylaxis. Omission is actually way harder to detect and is definitely more common in day-to-day clinical practice. Let's test this with a scenario. Imagine you're driving to work and you notice everyone on the road is routinely speeding. If we translate that to a hospital setting, where personnel repetitively and progressively violate standard practices until it basically becomes the new normal, what do we call that? It's called normalization of deviance. This is highly testable. A classic clinical example is when providers routinely skip proper hand hygiene before seeing patients. It's a dangerous shortcut that just sort of morphs into an accepted standard. Moving right along to Section 2, detecting and reporting errors. We have to systematically address both actual errors and near misses. Those events where an error definitely happened, but we got lucky and it didn't result in an adverse event. Whenever an adverse event or near miss happens, we rely on root cause analysis. This involves 4 mandatory steps: define the problem, develop a cause and effect chart, identify solutions, and finally, implement and review. The big takeaway here is that this is a retrospective, team-based review designed to fix systems and uncover latent errors. It is absolutely not about blaming specific individuals. Quick midstream pop quiz for you. Which of the following represents a team-based approach to retrospective review after a medical error or near miss to identify latent errors? Yep, as we just covered, that's a root cause analysis. And here is a high-yield nugget for you. The term itself is actually a bit of a misnomer. During a proper evaluation, you're almost always going to find multiple root causes contributing to the event, not just one. Okay, Section 3, we're looking at the critical role of communication, especially during handoffs, and the overarching need for a strong institutional safety culture. So since resident duty hour restrictions kicked in around 2010, the number of patient handoffs between providers has skyrocketed, and communication breakdowns during these handoffs, incredibly common. To fight this, you need to recognize these standardized mnemonics for the exam: SHOUT, SBAR, which is Situation, Background, Assessment, Recommendation, and IPASS. These tools are strictly designed to stop you from omitting vital patient info during care transitions. Another heavily tested concept is the second victim phenomenon. Patients and families absolutely need support after an adverse event, but the healthcare provider often suffers in silence. The second victim refers to the intense anxiety, loss of confidence, and psychological trauma that the physician experiences. Acknowledging this and providing structured peer support is a massive piece of building a true culture of safety. Let's shift gears to Section 4, Quality Improvement Frameworks. We're moving from reacting to errors to proactively building highly reliable systems. First up is the Standard Model for Improvement. It uniquely combines 3 guiding questions. What are we trying to accomplish? How will we know a change is an improvement? And what change can we make? It pairs those with the PDSA cycle: plan, do, study, act. The key thing to remember is that this framework lets you quickly test changes on a small, controlled scale before rolling them out for broad institutional implementation. Now, compare and contrast these 2 massive frameworks, Six Sigma and Lean. You absolutely must know the strict difference between them. Six Sigma came out of Motorola and is purely about statistics, specifically decreasing process errors to 6 standard deviations below the mean. Lean, on the other hand, comes from Toyota. It's all about process flow. It intensely focuses on minimizing systemic waste and maximizing patient value. Thinking about those 2 frameworks, Value stream mapping, which is a method to calculate efficiency or value added for each distinct step in a process, belongs to which specific QI system? The answer is Lean. Lean uses value stream mapping to sequentially document steps and basically trim the fat. It also uses the sequential 5S system: sort, straighten, sweep, standardize, and sustain. If you see waste reduction or 5S on your test, instantly think Lean. Finally, Section 5, we're covering specific, highly testable visual tools and metrics used to actually get these quality frameworks running on the ground. The Ishikawa, or fishbone diagram, is a cause and effect chart you'll see used all the time during root cause analyses. It categorizes multiple contributing factors, like staffing, communication, and protocols, that all point to a single problem outcome. In this case, a pulmonary embolism. Never underestimate the power of a simple, standardized tool. Checklists, like the famous WHO Surgical Safety Checklist, which breaks down into sign in, time out, and sign out, are proven clinical tools. They standardize the basics. They force a pause to improve team communication, and they've been statistically proven to drastically reduce operative complications all over the world. Last exam-style question for you. Which specific tool plots measured values sequentially in time to display the effect of a quality intervention? That is a run chart. It establishes a baseline median and then tracks your intervention over time. And that brings us to our final takeaway. Like the Institute of Medicine said, the vast majority of errors come from flawed systems, not reckless individuals. So knowing that, what specific part of your own clinical system are you going to redesign first?